Hello, everyone. This is Moal Sumidai with the Clinical Trial Vanguard, and I'm here with Mikael Boesen, who is the Professor of Musculoskeletal Radiology and Head of Research at Copenhagen University Hospital, Bispebjerg and Frederiksberg. Welcome, Mikael.
Thank you so much.
So from an imaging standpoint, how do you measure what's actually happening in the joint, and which modality gives you the most useful signal in a trial?
Every imaging trial of knee osteoarthritis require at baseline a radiograph of the knee standing in the frontal area, so you can see the tibial and femoral joint spaces. And you use that for inclusion because you have some features based on a scoring system developed in 1957 by Kellgren and Lawrence, going from 0 to 4 to include your patient. That is the mandatory part, but it only gives you some information regarding the let's say the grade of where you are the spectrum of knee osteoarthritic diseases. What you can't use the X-ray for, you cannot tell it anything about the soft tissue around the knee, the inflammation, the fluid collection inside the knee. GLP-1 has shown to give tremendous symptom relief, but the trial that are already out there, published in New England Journal of Medicine and Lancet and other important journals, they have only used the X-ray for inclusion. The drug works on the tissue inside the joint. You don't know what is happening with the tissue. You don't know whether there's a correlation between changes in some of the behavior of these tissues inside the joint and the effect of the GLP-1. This is what is basically missing.
Mm-hmm. And so your study showed significant weight loss, improved knee pain without detectable change in imaging markers of the synovitis. So how do you interpret that, and what does it mean for endpoint design in OA trials?
It reduces the appetite, meaning that you eat less and then you have a negative calorie balance and you lose by that a lot of weight. And we know from other studies where you have not used the GLP-1s, but just for weight loss, let's say dietary weight loss or powders that helps you to get the right nutrition with less calories, that weight loss induces symptom relief. But what is still missing to understand is why. What is driving this symptom relief? Because there's a mechanistic understanding that obviously if you take 10 kilograms off a load of a joint, then you don't load the joint with as much kilograms and thus have less pain. This is one way of looking at it, but it's much more complicated than that because the different drugs affects also the different tissues. So and it's not only tissues inside the joint; it's also tissue around the joint. It's the muscles, it's the tendons, it's the bone marrow, it's the synovium, it's the fat outside and inside the joint that are inflammatory drivers. Is GLP-1 giving, as a weight loss drug, giving symptom relief? Has it more than just a weight loss effect on the joint tissue? This is, is still missing to be understood. Whether this particular drug has an effect on the various tissues in and around the joint, meaning the synovium, the intra joint fat pad, called the Hoffer's fat pad, the cartilage, the bone marrow. There are some evidence suggesting that it actually has a direct effect on many of these tissues. But since the trials that have been run up until now, at least not with the latest compounds of GLP-1s, have not included any other imaging than the X-ray at baseline, not even a follow-up X-ray. When the trial finishes, then you have an issue with actually understanding this phenomenon to more than just the symptom relief.
DEXA is the standard for bone health in trials. So from your experience running multi-site studies, what challenges do you typically see, and what does a well-run DEXA program actually look like?
DEXA is used for bone health, but also can measure fat composition of the whole body as well as lean body mass, which encapsulate muscle as well as connective tissue and tendons. So you don't standardize the way these images are acquired. The settings of the within the scanner and control that on a regular basis with a phantom, then you end up collecting data that is not comparable. You engage with collaborators that can ensure that the acquisition of the data is similar based on a phantom scan. So you calibrate actually your scanner according to that specific phantom. You reduce the variability between vendors, between sites, between vendor versions and software versions.
Standard DEXA measures lean mass, but lean mass isn't the same as muscle quality. When does a sponsor need MRI-based muscle assessments, and what exactly is myostatiosis?
If you want to study muscle in particularly and understand what is happening to the muscle in muscle diseases like myositis, or what is happening during weight loss within the muscle, then you need to go to MRI, because MRI is the modality of choice for studying muscle. And there are many options here. You can quantify the muscles with volume. You can quantify the fat inside the muscles. You can quantify the fat between the muscles and the subcutaneous fat as well with the MRI scanner. This is basic standard sequences also required if you want to go for a drug approval focusing on muscle health. You can also add on newer technologies like the Dixon scan that can separate fat and water, so you can go more quantitative, so you can get true measures of fat and also water content of muscle. And you can do other sequences like T2 maps to get, let's say, a compositional score of how healthy the muscle is. When you do very large trials of thousands of patients, then you can use DEXA because it's widely available. It's relatively, let's say, straightforward to standardize. It can be run in multiple sites around the world. It can include fast. But it doesn't, if you really want to study the muscle, then you have to go to MRI, which is also doable. All the basic sequences every scanner can do. The more advanced sequences you want to use, the more strict you have to be in your site selection and in your questionnaires to ensure that when you include the patients that the site can provide whatever, let's say, methodology is needed. But that has to be known on beforehand, so you don't corrupt the data sampling. Myostatiosis, it's a fatty infiltration in the muscle. It's an aging phenomenon. We know, let's say, from many studies of the muscles that you can build muscle up till you are around 60. Between 60 and 70, you can maintain your muscle mass by regular exercise. And after 70, you can actually have very difficulty of building new muscles. And you even have hard time of maintaining the muscles that you have. So the advice is that you have to, in order to not be fragile or end up with having sarcopenia, which is the end state of myostatiosis, where your muscle cannot perform as acquired. So daily tasks are difficult, like let's say raising you from a chair or going upstairs, things like that. Then you have to do preventive intervention in your early ages, but it's never too late. Exercise works well, regardless of how old you are.
And speaking of MRI, what does DCE MRI capture that conventional gadolinium enhanced static MRI misses? And when is that extra sensitivity actually worth the added complexity in a clinical trial?
DC MRI is also called dynamic contrast enhanced MRI. It's a methodology that captures the behavior of the contrast while you inject it, and it diffuses into the various tissues that you image. The post-contrast MRI is kind of used for quantifying inflammation. If we're talking about knee osteoarthritis, then it's inflammation in the synovial tissue, in the fat pad of Hoffer, and static MRI kind of capturing the volume of that. But as osteoarthritis is a missing relapsing disease, then you build the size of your synovium over time. And the longer you've had the disease, you have fibrosis in the tissue, so it doesn't fluctuate that much in volume, even though you have activity. And this is where DCMRI has a true benefit, because it can, within a given volume, measure the perfusion or distribution and the speed of contrast uptake. So you can actually get a more granular information of where inflammation is and how fast it reacts to a certain treatment. It correlates best with when you do biopsies and look in the microscope after inflammation. It's most responsive, so when you give very potent inflammatory inhibitors like steroid, you can see changes within a week on these DCMRI, let's say, measures, which you can't see on the static measures. So it adds sensitivity and granularity of inflammation. If you have decided to give contrast anyway, to do post-contrast imaging, then DCMRI only takes 3 to 4 minutes extra scan time. Acquiring the sequence, every scanner can do it. It's not difficult. You inject with a power injector or even manually, and then you flush with saline. And then you uptake these data that then can later be post-processed. For osteoarthritis, because without using contrast, we don't know how to separate effusion, meaning water in the joint, and the synovium. So there's every good reason to consider DCMRI every time you have considered that you need contrast.
What is the most exciting or underutilized imaging tool for the next generation of musculoskeletal clinical trials?
If we're talking about osteoarthritis, I see this evolve. It's a moving target, and it's evolving also with the newest technology that is available. We see a rise in the use of CT scanners, and CT scanners is a three-dimensional X-ray. And these scanners have matured a lot in the last 10 years, because it can also, when you analyze how the tissue absorbs the radiation beam, then you can begin to do a material decomposition, meaning you can study the bone trabecula. The newest generation called spectral CT scanners, they even have a resolution less than 100 microns. So you can actually, it's becoming a microscope. And I think that will add a lot to the value of understanding the bone health issue. You can also use every CT scanner as a 3D DEXA scan. So you can actually get bone health or trabecula. You can get a T and a Z score from a CT scan, because it's three-dimensional, and it has the benefits that it's not prone to, let's say, less sensitivity. If you lose a lot of weight, then the DEXA becomes less, let's say, less viable or less. It comes with more noise because the distance inside the patient is reduced. So that introduces a calculation bias from the 2D DEXAs that the 3D CT scanners, because of the design and the 3D modality, is not prone to. So I see that this is raising a lot in bone health. We also see a lot of new MRI sequences coming out. Very interesting, there's a non-contrast contrast behavior. It's called double, let's say, inversion recovery flare images, where you can separate fat and synovium. These are interesting. You're also beginning to see more, let's say, tissue composition sequences or multi-weighting sequences that is coming out there. Even 5 minutes knee scans where you automatically segment the cartilage. So all of that is because of the AI, and introducing AI into sequence selection as well as reconstruction. You gain a lot of benefits in signal to noise, as well as in new possibilities in coming trials.
Thank you so much, Dr. Boesen, for joining us today.
Thanks a lot for being here.